Welcome to another episode from the Veterinary Research Channel. Today we are diving deep into a common yet complex challenge faced by veterinary professionals: collecting uncontaminated urine samples from our canine patients. Urinalysis and urine cultures are essential diagnostic tools for screening dogs for urinary tract infections. The quest to obtain a urine sample safely, non-invasively, and sterilely from a dog is a difficult task. The study we're covering today looks at different urine collection methods in dogs, focusing on minimizing bacterial and cellular contamination during collection. To start, there are three primary methods for collecting urine samples: cystocentesis, catheterization, and the standard clean catch method. Cystocentesis, or CYS, is often preferred because it yields the lowest number of urethral contaminants. However, it's not always a walk in the park because it requires a cooperative or sedated patient and a technician skilled in the procedure. The bladder must also be sufficiently full. Even when done correctly, cystocentesis carries risks, including iatrogenic aortic puncture and hemoabdomen. There have been reports of septic peritonitis, blood clots, and bladder tears following cystocentesis. Plus, it can cause spurious hematuria, which can misrepresent the actual condition of the urinary bladder. The clean catch voided method is popular in veterinary medicine for its simplicity and convenience. It's easier to have a patient urinate outside and collect a sample, avoiding the need for physical or chemical restraint. However, this method has higher bacterial contamination rates because the urine passes through the non-sterile urethra before collection. So, how can contamination be reduced? One method involves collecting a midstream urine sample, where the initial urine stream is discarded. This is standard practice in human medicine because it washes away the resident bacteria in the urinary tract. However, collecting midstream samples consistently from dogs can be difficult. Typically, clean catch samples are taken by placing a container into the urine stream as the dog urinates. Ensuring enough urine is voided before collection, while keeping the container in the stream to get enough volume, can be tricky. Therefore, it is unclear whether current clean catch practices yield similar results to true midstream collections. This brings us to the heart of the study: evaluating a midstream collection device, or MCD, designed to discard the initial urine and collect the rest in a sterile container to see if it reduces bacterial contamination compared to standard clean catch methods. The researchers hypothesized that the MCD would reduce bacterial colony-forming units per milliliter and cellular contamination. The study was a descriptive cross-sectional one that included 41 client-owned dogs weighing at least 15 kilograms. Smaller dogs were excluded because the MCD discards 10 to 20 milliliters of urine, and smaller dogs may not produce enough urine for the device to function correctly. Additional exclusion criteria included recent antibiotic use or a history of lower urinary tract signs. Dogs that could not undergo cystocentesis safely without sedation were also excluded. For the standard clean catch and MCD groups, dogs that didn't produce enough urine or had behavioral issues preventing collection were also excluded. The midstream collection device used was the PZ Midstream device. This device captures true midstream samples by allowing the first 10 to 20 milliliters of urine to pass through as a cellulose sponge expands. Once expanded, the sponge blocks additional urine, diverting the remaining urine into a sterile collection tube. The device, originally funnel-shaped, was modified into a half funnel to accommodate female dogs. After enrollment, urine was collected via standard clean catch, MCD, and cystocentesis within a 7-day period. The collection order was randomized to account for potential hematuria caused by cystocentesis. Owners were asked about lower urinary tract signs during this period, and any dog developing such signs would have been excluded. For standard clean catch, a clean receptacle was placed into the urine stream, and the sample was transferred to a sterile cup. The sample was collected as quickly as possible to mimic typical veterinary clinic practices. For MCD collections, the sterile device was placed into the urine stream, diverting the sample into a sterile collection tube. Collections were deemed failures if insufficient urine volume was collected. Cystocentesis was performed with the dog in dorsal recumbency, using a sterile needle guided by palpation or ultrasound. Cystocentesis samples were considered failures if they could not be collected safely without sedation or if there was insufficient volume. Urine samples were analyzed within 30 minutes at the University of Wisconsin-Madison Veterinary Care, Clinical Pathology, and Microbiology Laboratories. Urinalysis, including dipstick and sediment analysis, was performed using standard techniques. Quantitative aerobic urine cultures were also performed, plating 10 microliters of urine from clean voiding or 100 microliters from cystocentesis. Cultures were evaluated after 24 and 48 hours, and bacterial isolates were identified and quantified. Data collected included the presence or absence of protein and heme from the urine dipstick, the presence or absence of red blood cells, white blood cells, squamous cells, and transitional cells from the urine sediment, and the presence or absence of bacteria from the aerobic urine culture. Statistical analysis was performed to determine the prevalence of each sediment or cell type, using percentages and confidence intervals for each collection method. Generalized estimating equations were used to test for differences between collection modes, accounting for multiple detections within the same dog. From the initial screening of 41 dogs between June 2021 and April 2022, several were excluded. 2 were excluded due to safety concerns during cystocentesis, 7 because of insufficient urine volume collected with the MCD, and 6 due to owner disenrollment or the dogs exhibiting aggression or anxiety. The challenges with the MCD were primarily in female dogs that squatted too low and male dogs that urinated in small amounts. Ultimately, 26 dogs met all criteria and completed the study. The study population consisted of 12 spayed females and 14 neutered males, with an age range of 1 to 11 years and a mean age of 5.5 years. The dogs weighed between 15 and 34 kilograms, with a mean weight of 23.5 kilograms. The study included 11 different pure breeds and mixed breed dogs. The MCD was the first collection method for 14 of the 26 dogs, with cystocentesis performed on the same day for one of those 14 dogs. Standard clean catch was the first method for 6 dogs. When cystocentesis was performed first, the other methods took place 1 to 3 days later. The study compared urine sediment, dipstick, and aerobic urine culture results to determine if MCD samples had fewer cellular components and bacteria than standard clean catch samples. Among the variables assessed, only the prevalence of squamous cells and positive aerobic urine cultures differed significantly among the collection methods. The prevalence of squamous cells did not differ between standard clean catch and MCD, but cystocentesis showed lower prevalence compared to both. Similarly, positive urine cultures showed no difference between standard clean catch and MCD, but cystocentesis had a lower prevalence compared to the other 2 methods. Specifically, 30% of the MCD specimens had at least one bacterial species identified, and 23% had more than one isolate. For standard clean catch, 46% of specimens had at least one bacterial species, and 26% had multiple isolates. In contrast, only 3% of cystocentesis specimens had one isolate, and none had multiple isolates. The data indicated that midstream collections do not significantly differ from standard clean catch methods in veterinary medicine. Both collection styles frequently resulted in bacterial contamination. The bacterial species isolated from MCD and standard clean catch samples were consistent with normal urethral microbiota, common skin inhabitants, and common contaminants from the gastrointestinal tract. It's worth noting that none of the MCD and standard clean catch samples had more than 100,000 colony-forming units per milliliter of bacteria, which is the cutoff for determining significant bacterial counts in voided samples. Even with midstream collection and a sterile device, bacterial contamination levels from the urinary tract and skin were similar to those found with the clean catch technique. The number of squamous cells was also similar between MCD and standard clean catch samples. This suggests that regardless of when the urine collection is initiated, cellular contamination still occurs as the sample passes through the urethra and external genitalia. Comparing free catch methods with cystocentesis revealed differences in cellular and bacterial contamination. Standard clean catch and MCD samples had more squamous cells than cystocentesis samples. This is because cystocentesis bypasses the distal urogenital tract, reducing cellular contamination. Surprisingly, there were no significant differences in red blood cell presence among the collection styles. A significant limitation of this study was the number of dogs excluded, which was 36% of those screened. This limited the statistical power to assess additional differences, such as bacteriuria detection in male versus female dogs. Many exclusions were due to difficulties with the midstream free catch device. The difficulties encountered when using the Midstream urine collection device would likely prevent its routine use in veterinary clinics, regardless of its ability to reduce urine contamination in voided samples. In conclusion, cystocentesis remains the most accurate method for collecting urine and is recommended when accuracy is crucial. However, cystocentesis isn't always practical due to factors like patient compliance or a small bladder. This study shows that standard clean catch or MCD techniques are suitable alternatives. Collecting a midstream sterile urine sample did not yield statistically different results from collecting a voided sample into a clean container. When using any free catch technique, clinicians should consider the patient's clinical signs, the colony-forming units per milliliter detected via culture, and the organisms detected because bacterial contamination is common. Thank you for listening to the Veterinary Research Channel. A link for the referenced paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.